This conference will now be recorded.
You are staying here or going just before before I forget, just take now. Okay. Hello, am I audible?
Yes,
Audible,
sir.
na? Huh?
Yes,
Yes.
sir.
Okay. Very good morning to everybody. So we'll discuss intrauterine growth. I think it has been discussed so many times. Just it is a repetition. We'll just discuss little bit what the what is the IUGR incidents are, that is pathogenesis, diagnosis, and that is other thing is management. So just we'll discuss all these things, intrauterine growth retardation. So what is intrauterine growth retardation? So we'll define it. So normally baby growth of the baby depend upon genetic factors of the baby, or that is factors of disease, and whether the mother is consuming, whether she is a nutritional substance is consuming, is adequate or not, whether that whatever she is consuming, whether it is properly is going to baby or not, for placenta, so we have to discuss all these things. So first, they depend upon the growth of the baby depends upon genetic factors of the baby. Then whatever the health of the baby, whatever mother is consuming, whether it is properly baby is getting from that nutrition or not, just we'll discuss this. By definition, that again that is there's a sonographically estimated fetal weight below the 10th percentile of the gestational age. Other things are there, that is fetal growth restriction and small for gestational age are not. So this terms has been used so many times simultaneously. Earlier days when baby the pediatrician use small for gestational age. But that's after delivery they'll wet the babies. That's something. That's earlier that it is something waiting baby after delivery when the ultrasound was not there. So it is after the birth of the baby, not before the birth of this baby. But now after introduction of this ultrasonography, we can estimate the baby weight inside the uterus. So before delivery, antenatally, whether baby is growing properly, all these things. Earlier days, only per abdominal examination that is there. But that may not be correct, all these things. But now we are being more detailed that, that is measuring this body parts and just estimating just the expected baby weight or that is also. So that is all this, that is the for kindly sonographically estimated fetal weight below the 10th percentile for gestational. How you will know it is below the 10th percentile? Below the 10th percent. So that is all these things in this percentage. What happened, that is sonologically we are estimating baby weight, particularly at 40 weeks. Suppose we are waiting 40 weeks. There are 100 babies in 40 weeks gestation. They are taken, that estimation is taken and put in chronological order. That is also 1, 2, 3, 4, go up to 1. Those who are falling, that is below the 10th, initially below the 10th, weight wise. Weight was 1, 2, 3, 4 below the 10th. These are called as a 10%, less than 10% below. If it is more than 90%, that is discussed, and that is among the average all these things. So 10th to 90th is taken as average. If it is less than 10%, that is it is underweight, or that is a small per day, or if it is more than that, overweight, or more than average weight. So 100. So similarly, at 36, with the with respect to period of gestation. Similarly, if it is a 36 weeks, 100 babies are taken, weight are taken on this thing. This we are calling less than 10, your calling is less than percent. This is all this thing is there. So percentile of this thing is there. So that is also again it depend upon that all this thing how the baby is growing on this. Normally for growth of the baby, there are major things or the important things are the oxygen, glucose and amino acids. This is the responsible factor all these things growth of the. So first thing is oxygen. There should be sufficient oxygen, glucose. This is again supplying energy, glucose. That is also an amino acid. That is the protein you need of growth of the baby. So normally what happens in early age of embryogenic stage, early as first trimester, around 16, it is the cellular hyperplasia. It is an increased division of all these things, cellular hyperplasia. So it is the initial stage of the life, embryonic stage. It is cellular hyperplasia. After that, 16 to 30 weeks, first 16 weeks is cellular hyperplasia. After that, hyperplasia and hypertrophy, where the cell size also increases, cell number also this. So number and size both is increasing. That's why there's a growth of the baby, weight is also increasing. After 30 weight, there is no more hyperplasia, all these things. Only hypertrophy will be there. That is so in initial stage, there will be cell number will be increasing in middle of this pregnancy, hyperplasia, hypertrophy, both are there, that is also, and after 32 weeks, that is the increase in size of the cell. So this is all this thing is here having this pattern. So that is how it affecting growth of this baby, growth of this. So majority of these cases is due to defective placentation. There is an abnormal placentation. If there is an abnormal placentation, then we are having what we are having, that is also decrease in the circulation. This disease circulation causes decreased oxygen supply. So this is if this placentation is not proper, that is because placenta, that whatever baby get nutrition is through placenta. That is it. And how it get, that is the blood supply is there. There will be villus and placenta. There will be interaction between there. That is the exchange of oxygen is there, and from that baby get that is all these things. So if any pathology in placentation or abnormal placentation, then there will be IUGR. So what happens in normal condition? What happens, that is baby receive blood supply from the uterine artery, then it goes inside the uterus, the radial artery, that's arcuate artery, radial artery, spiral artery, all these things, and again that is communication. Again, this is placenta is there, bolus is there, incroing of bolus toward this myometrium is there. So that is a in this between, that is all these things interaction between placenta and myometrium. That is also when there is there that villus, that is what is there, this is that is trophoblastic cell that goes inside the blood vessels and destroy this intimal layer, all these things. So there will be dilatation of the vessels. Here you will see this is all this thing. There will be macrophages action is there. That is also, that is invasion of the macrophage, that is trophoblastic cells, and intimal layer is renewed. That is also. So there will be dilatation of the vessels, particularly spiral vessels. Spiral vessels dilated, that is all. So there will be normal blood supply, and that the baby gets nutrition from that. In case of eclampsia or pre-eclampsia, you can see here it is, you can see that is there is no proper invasion of the trophoblastic cells. So all these vessels will be this rigid and not proper dilatation, all this. So there is the capacity is reduced, so they'll get less oxygen supply. So that is. That is also. Here you can see that is again, that is all these things. In case of absence of all these things, invasion, improper invasion of this that trophoblastic cell, that is it, then there will be no dilatation of the spiral artery. So there will be less supply, hypoperfusion, and fetal growth rate. They will not get proper nutrition. This is this growth patterns in this intrauterine life, all these things earlier. Yes, I told you it's the first half, that is 1 to 16, 14, which is per day growth of this baby. That is, they'll gain 5 gram per day at 14 to 14. When it increased to 15 to 20 at 20 weeks, and that's a maximum gain is 30 to 35 per day, around 30 to 34. So thereafter, that growth pattern will decrease. That gain of weight gain will decrease all these things. So this is the baby's growth. So earlier that's 5 gram per day at 14 to 15, at 20 weeks, 15 to 20 grams, and 30 to 34 weeks, maximum gain at 35 to 30. So this is all this thing that is baby gain is there. If any deviation or decreased growth is there, then we'll have IUGR. So there are so many nomenclature classifications of IUGR, small per date, all these thing is there, just will be. So basing on the fetal weight, all these thing, low birth weight. Anything less than 2.5 kgs is a low birth weight. Very low birth, that is also 1.5 kg. But if it is a less than 1 kg, it is still low. When all these things will again, that is, and related to the fetal survival, if it is a IUGR severely, I guess mortality will be very high, 50 to 100%. That depending upon baby weight, and future of the baby depends on that is a baby weight, all these things. So I already told you percentile, all these things. Basically, average gestational age for gestational age is 10 to 98%. 10 to 98%. If it is less than 3, it is very severe gestational, all these things. So small for gestational is less than. If it is a large for gestational, more than 90 is. So 10 to 19 is a normal average gestational. As all this thing, all this, that is also. So if it is less than 10, we'll see small per gestational age, or it is intrauterine growth retardation. That is all this thing. So classification, I told you all these things. That is also, that is classification is symmetric and asymmetric. So this is ultrasound classification, symmetric or also, but symmetric and also you can also clinically detect, but not before delivery of the baby, only after delivery. So I use symmetric, asymmetric, and intermediate. Symmetric is type 1, asymmetric type 2. All this thing is there. That is. So accordingly, all these things, the overall incidence 10 to 15% of IUGR will find all these things. Out of them, all these things, 20 to 30% are symmetric, and 70 to 80% are asymmetric. Symmetric is what is all this thing that uniformly small. When that is IUGR, those babies are less weight, but symmetric. That is a head of growth, abdomen growth, inner growth are corresponding. That is also is there. Small head circumference, small BPD, small abdominal, all these things, but there is a normal. That is answer. But asymmetrical, where this asymmetrical growth is head circumference bigger than abdominal circumference. They are pathological. This is pathological. This is also pathological, but what happened? This is a some type that may be due to a small, that is stature, all this thing is there, genetical factor is there. Yes, it is mostly that is the placental diabetes, hypertension, all these things. Here, all these things asymmetric, relatively liver size, all these things small, all these things. So symmetrical, uniformly small, and asymmetrical, it is the head circumference is bigger than abdominal circumference. So though growth pattern is all this. So that is fetal organ decrease proportionately. That I told you all the structure will relatively small. That is also. And here it is abdominal size is less than the head circumference relatively. Causes again it is also impairment of hyperplasia items. It may be genetic condition, structural or racial factor is also is there. But here it is a pathological, all this thing is there, placental implantation, all this thing, lack of nutrition, all this thing is there. So that is it's symmetrical, mostly it's detecting in early gestation, and asymmetrical, it detects in later half of the pregnancy. So symmetrical is uniform or proportional is small, and that is asymmetrical is proportionately small. Here both are small, but this is high. And in between is all this thing is intermediate. There is there. So this is all this thing. So other classification is also there. That is also intrinsic factor, extrinsic factor, intrinsic factor, extrinsic factors, and that is combined. Intrinsic interest combined, and sometimes idiopathic. This is also one more classification. Is intrinsic is basically fetal condition, extrinsic is maternal conditions and this thing, and combination of this, and when this cause is not known, that is also. So etiological factors, I told you all these things. It's maternal condition is responsible majority of cases, 70 to 80%. Only that is fetal case is 20 to 30%. So maternal risk factor, it is maternal factor, again it is a maternal risk factor, maternal medical disease, and associate with obstetric conditions. So again, maternal conditions, extreme age of pregnancy. If it is adolescent pregnancy, teenage pregnancy, then again it is teenage pregnancy, adolescent pregnancy, that is against. So that is uh, teenage pregnancy. Parity again, it's nulliparity. Nulliparity again, that is again more affected nulliparity. Weight of this mother, extreme weight, either it is too low BMI or high BMI. So both side it is like teenage or elderly patient, that is here also extreme is also. So that is also BMI, that is also is good. And those who are daily worker, exercise, all these things, that is also is good. Substance abuse, alcohol, drugs, all these things. Again, these are contributing factors. Maternal risk factor is also. The extreme is nulliparity, multiparity, all these things is also extreme weight, that is also exercise, daily worker, laborer, alcohol, drugs, so these are all medical disease. I told you hypertension, this is because of improper implantations of the placenta. Hypertension, that is also because most of the hypertension placentation is abnormal. Diabetic, when there is a vascular, it is vascular involvement of vessels, uterine vessels and placental vessels. So diabetics, you will have anemia, sickle cell disease, these are cardiovascular disease. There is a decreased oxygen supply. We will get all these things. Other renal disease, antiphospholipid, this also import contribute for, that is IUGR, that is also. So anemia, sickle cell disease, cardiovascular, because mostly this is anoxic condition, that will again that is less of oxygen supply, so baby will not go properly. That is other obstetric condition, that is a small for earlier history, previous history of stillbirth, small for gestation is preeclampsia. Preeclampsia, if you see here the preeclampsia, there may be repetitions of recurrence of this thing. Then pregnancy interval, I told you multiparity, all these things can occur. Heavy bleeding, first trimester, certain abortion, all these things, placenta previa, eclampsia, all these things, abruptio. This has also that is can contribute for abnormal disease. Again, fetal condition, I told you fetal condition, it involves early gestational age, basically that's trisomy or Down syndrome, all these things is a mutation. These are all this the genetic factor is there, that is answer. And other vectors is cytomegalovirus, that is infection. So if it is a fetal condition, it could be the genetic factor or that is infection. So mostly torch infection is responsibility for this. This is IUGR. So again, this placental condition, that is also, that is because it's a maternal condition, it's placental condition. This chronic placental separations, that is maybe abruptio, all these things, abruptio, placenta previa also responsible. Circumvalent placenta and hemangioma is pathology is the hemangioma, all these things. Infraction, that is infraction is the other. Other like cord abnormality, filamentous insertion, marginal cancer. Sometimes that is single umbilical artery, vasa previous. So true knot or false knot or cyst, central cord cyst, you'll find all these things. It also affect this growth of the baby. So now we are monitoring during all these things. We have a proper chart is there. That is a standard chart. Is there any deviation from that? That is also two standard deviation is there. Then we'll that is we label it that abnormal growth of this baby. That is also. So we have other thing is clinical measurement. All these things, even weight gain every 2 weeks we count then per abdomen, fundal height, all these things. But now we have a very reliable thing is that is ultrasound, that is evaluations of the growth. Not only it is a IUGR will detect the type of IUGR, symmetrical or asymmetrical. Not only IUGR, all these things, even fetal surveillance can be done through ultrasound, through Doppler, or all these things. How much blood is flowing to fetus, all these things. You can record all these things and measure all these things. So this is all this thing. It's the fetal surveillance. What we are doing, all these things. If there is no fetal growth satisfactory is not there, we have to monitor properly all these things. That fetus is not distressed, all these things, we can improve until 25 months. Any IUGR baby, if there is no abnormal is detected, all these things, that is answer. So this is also you have to monitor if it is there. But if any time there was a distress, all these things, it has to be delivered. Because internal environment inside uterus, something wrong is there. So there may be danger to the baby if she is not delivered. Once she is delivered, maybe outside sun, all this. But baby has to be mature. Fetal lungs should be matured so that we can deliver. That is the titrating the patient on this thing. Then we have to deliver the baby. So daily fetal movement. How we'll monitor all these things. We'll detail discuss later on. But this is thing daily fetal movement score. At least 10 movement within the day. All these things. 10 movement, 10 to 12 movement, that is movement, that is also. Other test where biophysical profile, where the non-stress test, we'll discuss later. Biophysical profile, amniotic fluid index, growth pattern, sonography, Doppler study. These are all these things you are doing on this. Diagnosis. Once you detect that is this thing or suspect this baby, detect on this thing or suspect the baby, then we have to diagnosis, proper diagnosis. Sometimes there may be wrong diagnosis, may not be knowing the actual age of the fetus, all these things, maybe they may not be remember menstrual cycle, all these things, and unnecessarily will terminate baby, that is also caused. So we have to confirm the date of the patient, clinical exam. So history is very important. When is the last, whether she has conceived during lactational periods, when she has taken some oral contraceptive before conception. So the date should be accurate, whether she had done that ultrasound in early period of gestation. So exact date of conception should be knowing on this thing. Once you know all these things, you can label this IUGR on this thing. Risk factor determination of gestation, as I told you, retention of gestation very important. Without that, always it will be will wrongly diagnosis in this thing, unnecessary intervention will be occur. So clinical history taking is very important, particularly period, and the nature of menstrual cycle, whether it's conceived during lactational period, so her period were irregular or regular, whether it has oligomenorrhea cycle, all these things, whether she has conceived after the oral contraception. So we have to find all these things. So that is a diagnosis should be done. Then other thing we do is investigation. What we do is investigation because all this thing. Sometimes when the investigation will detect some of the suppose hemoglobin is low, maybe she is suffering from hemoglobin, and that is suffering from this malnutrition, all these things. So we have to do this routine hemoglobin. Another thing is specific investigations. When you detected, that is when you detected this is baby is not growing, we have to do routine investigations. Normally we will do for all patients. The routine investigation. RS factor, suppose RS negative, again they are made fetal is all this affected baby, all these things. So this is a specific investigation ultrasound. Though we are doing ultrasound routine basis, but specific ultrasound like growth parameter, running all these things, amniotic fluid injection, bioprotons. So detailed investigation will be doing on this thing. Again, specific investigation apart from this hemoglobin or this thing, torch infection. If previous baby has that is affected baby toxoplasma or cytomegalovirus. These are also responsibilities. Other specific cases for fetal monitoring, NST, biophysical profile, and Doppler assessment of this as well. So we can know the condition of this method of IUGR in this disease. That is how we will know IUGR is there. Whenever you are sitting in this antenatal clinic, first thing we are taking this is a first visit. We will name that record the weight of this mother, that weight of the mother, height, all these things we'll see so that we can calculate BMI, all these things, first visit. And successive visit, what we are doing is each visit is important. So we are taking weight of the patient. So we are determining how much weight gain is there. Ideal weight gain, so within 2 weeks, at least 5.5 kg should be increased. If it is excessive increase or not all increasing or decreasing, all these things is there. So we'll take in symmetric cases, initially there may not be there may not be that is different decrease in weight gains also, but later half asymmetrical, again there will decrease in later half of this. So that is also that per abdomen examination fundal height. Fundal height, we know that is also symphysis pubis is just palpable. Symphysis pubis is 12 weeks, 24 week umbilical, 36 weeks GP sternum. And again in term pregnancy, it will come down to 32 to 34 weeks, but plants should be filled, all these things. So this is all this para-abdominal exam. But before that, one has to keep in mind patient has emptied her bladder before examination. Sometimes you have not told her to empty her bladder and there will be unnecessary height will be more than normal. That is what we are expecting. So before that, her bladder should be put her in abdominal position, that is the supine position, and correct her restore rotation. That is also. So make it upright and then palpate all these things. So this is all this thing symphysis height. And you can measure symphysis pubis height from symphysis pubis to all this thing. So just you measure all these things with centimeter and centimeter. After 25, it is correspond with period of gestation. So there will be that is increase in forward. So you can find that is also. 1 centimeter per week increase is there. But roughly we'll see if there is a per abdominant. If it is more than 4-week discrepancy is there, it suggests some IUGR. If it is more than 6 weeks, it is severe IUGR. So we have to listen. And taping measurement also, you have to see that is also, if you take all these things, mark the point, then you measure all these things. Preferably you should this marking side of your tape should be not visible inside the abdomen, or sorry, that is also posterior to that is also the marking should be high, so that you should not be confused with this uh, that is measurements. So this is all this thing we can give. If the suspect is there, then sonography. Sonography, I told you, it is a better equipment to know this. This IUGR. You can also know symmetrical, asymmetrical IUGR. So you can know the different symmetrical. That is the advantage of all this thing. Again, you can monitor this fetal surveillance, all this thing. So ultrasound has definitely added advantage of all these things. So fetal biometry, they are measuring femur length, BPD, abdominal cath, all these things. Placental morphology, again we have amniotic. These are the main thing, fetal biometry, placental morphology, amniotic fluid volume, all these things. So these are we are measuring all these things there. That is. So that is it. Fetal biometry. What we are measuring is BPD, femur length, abdominal circumference, and this thing. Head circumference, abdominal circumference, transcellular diameter, all these things. BPD from one biparietal diameter. That is the transmission, because we are measuring biparietal from one side to other side of the parietal eminence. And it is a thalamic level. Thalamic level. That is it. So it is that is also scan. Head circumference, again that is circumference. That is a better indices that they have. And again that is transcerebral diameter. If this that period of gestation is not confusing, that it's a patient doesn't. Transcerebral diameter is a better parameter to detect IUGR on this. Abdominal circus weight parameter, because abdominal circumference at the level of this that is umbilical portal vein, that is when there bifurcation of portal vein is, you measure umbilical gap, and roughly you can get umbilical level also is there. It indicates this mass, the abdominal organ, that is particularly liver. If it is a liver is immature or that is some defective, then we will have it is abdominal the circumference it's reduced, and that is the most sensitive indicator. Head circumference by abdominal circumference. It is a decrease, then again that is increase, then you'll have that is IUGR on this thing. So head circumference by abdominal circumference. Other parameter is femur length. Femur length also does not affect. Head circumference, femur length, it doesn't affect with IUGR. It will remain constant for all these things. But abdominal will affect it with IUGR all these things. So we can, if it is that risk is increase in a decrease in abdominal circumference, it indicates there is IUGR all this. So that is also this is there. Then placental pathology. If it is a hyperperfusion, all these things, the volume of the placenta will be less. Normally, this volume of this and weight of the placenta should 1/6 of this baby weight. But in case of IUGR, both will be decreasing on this thing. So that is so placental grading and all these things we can do is a constant homogeneous structure is this grade 0 placenta. Grade 1 will see some little bit calcification is there, that is it's a grade 2. Grade 2 is this, sorry, grade 1. Grade 2 again that is calcification, that this is more, all this thing will see that. Grade 3 again fallout, and that is fall out in content of this placenta. Or sometimes the calcification will be more mature. That is, anything more than grade 2, we'll call it mature placenta. So when we are deciding for termination, if you see grade 2 placenta, you can go for termination of the pregnancy. But if you are terminating when it is a grade 1 less than grade 2, again baby may suffer from this premature. That is asphyxia, all these things. Amniotic fluid volume, again, that is a very innocent. IUGR is always associated with oligohydramnios because supply is less, oxygen supply is less, circulation is less, so there will be urine output is less and amniotic fluid will be less of this thing. So normal, that is also that is amniotic fluid, we are considering 8 to 25 is normal. Any single pocket 2 to 8 is normal. Any deviation from this we call is oligohydramnios on this thing. Once it is oligohydramnios, the liquor is less. There are so many problems will be there. Again, cord will be compressed around this baby because liquor is less. Once this contraction is there, again there is the circulation. Again, baby will suffer more and more from this. So baby will suffer more and more all these things. So any pocket less than 2 centimeter, this is termed as oligoid. Any single pocket, all these things. But if it is a amniotic fluid, will take 4 quadrant of this abdomen, that is also vertical pocket. That is upper right, upper left, lower out, lower left, all these things. And somewhere else, here, 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 here. We'll just sum up all these pocket centimeters. If it is fall 8 to 25, it is normal. If any deviation from decrease from that normal, we call it oligohydramnios. So perinatal, we know that is when there is a IUGR, all these things, perinatal mortality is very high, more than 50%. If it is very severe, less than almost, it was 80 to 90%. So we have to take care of all these things. So in this sense, that's when there's a circulation is decreased. How we'll know? We can know from Doppler blood flow. Normal blood flow is continuous blood flow towards the heart is there during whole cycle of the cardiac cycle. So if any point there is a absent or reversal flow towards the baby, that's sorry, away from the baby, then again it will be very suspicious. In this case, it's reversible flow or absent flow, that mortality almost is 100%. Therefore, any patient you have detected is reverse of flow or absent should be delivered immediately. Otherwise, there will be IUD. That is. So normally what we'll do is the Doppler ultrasound. We'll just pick up the uterine, umbilical, middle cerebral ductus venosus, umbilical, inferior vena cava. Mostly in our uterine, umbilical, middle cerebral. So we are doing all this. In case of normal, what is it? But in case of IUGR, what about PIRI will be elevated on this thing. Again, that is umbilical ultra, same thing, it is elevated on this thing. But middle cellular, there's again, there is a transferring capacity, it will be decreased. Once it is decreased, again there is ductus venosus. I told you if it is a reverse flow, absent flow, then baby is in all this thing. So that is all this thing. Any reversible flow, all this thing will very high risk for baby. So normally what happened? Normally, gradually, what will happen? Uterine, umbilical, middle cerebral, then inferior, then intracardiac. That changes will be occur sequence. Undergraduate, we may not having all these things, but this should be first uterine, umbilical, middle cerebral, inferior, and umbilical reverse flow. That is also. Management, again, this management depend upon management. Again, this is early diagnosis. It's the diagnosis of this. So first thing you have to correct the period of gestation. Period of gestation on this thing, that is early identification. Early identification is there. That is, if you identify it early, then you can plan accordingly, treat the causes on this thing. we will just plan for this, and that is RD and fetal surveillance, that is condition of the baby. How is this baby? All this thing, and plan for delivery. That the appropriate time to deliver baby and mode of delivery. Which route we are giving vaginal delivery or C-section, all these things. So it is very important when you find the IUGR, the first thing you just find out the type of IUGR, whether it is symmetrical or asymmetrical. You have to find out all these things. If it is asymmetrical, what type of this organ is there? What are the causes of this IUGR? All these things. So that is a fetal surveillance. How frequently you survey? What are the method of fetal surveillance? Whether you fetal movement or ultrasound scanning on NST will do all these things. And that is what treatment you are giving. Depending upon this causes, etiology, you have to manage this patient, all these things. And plan for delivery. Whether you'll at what time you'll deliver, whether you allow her till term or you have to terminate before that. You have to see all these things. So all this management depend upon, because you are not alone seeing this baby. You need your staff, that is for gynecologist, pediatrician. More important is pediatrician. So neonatal unit, whether you have a proper neonatal unit to deal all these things, that is also. So first thing you have to decide where to deliver all these things. If there is a no pathological detected, all monitoring is normal, you can allow, that is normal delivery. If it is any abnormalities detected, baby is in risk, better should be terminated in tertiary case where neonatal ICU is there and where cesarean section facilities are there. Will help of this thing. So you have to decide moment you get patient, you have to decide. So etiology, that is, I told you what is the causes of the IUGR. If it is that is a hypertension patient, you have to treat the patient on this thing. If it is a diabetes, you have to treat the diabetes. If it is so, that is the first thing you have to face on this thing. So clinical examinations where is the height, weight, all this thing, diet, all this. So this is very important, all these things. So you have to do proper test investigation, also routine test and specific test on this thing, and specific ultrasound test on this thing. So ultrasound restricts, I mean, all these things. You have to find out it. So treatment of underlying cause, hypertension, cessation of smoking, protein energy sample for nourish all these things. Because I told you essential thing is oxygen, glucose, and amino acids. If this not provided properly, all these things. If patient is whether properly taking diet or not, if it is not. So normal diet you have to, and all these things is sufficient. So how much diet you should give, all these things as per the body mass index. You have to calculate diet on this thing. If it is a very obese patient, you have to restrict. If you is a very thin malnourished, you have to increase your diet. And protein energy supplement is very important. For all pregnancy patients, you have to add sufficient protein. Normally the protein requirement for patient is 1 gram per kg of body weight, but in pregnancy we have to add 15 gram extra for this pregnant woman. So that is, if patient is 50 kg, you have to pay 50, 65 kg grams of protein for her on this thing. So this is on this thing. So if it is nothing is there, we have to get, maybe patient is daily working, she is not taking sufficient rest. Bed rest. Rest is very essential. Normally 8 hours sleep during night and 2 hours during daytime after lunch, just preferably after lunch, because since our Indian population are poor families, they may not get sufficient time to rest, all these things, their labor daily workout. So basic things. One is IEGR is better to take rest or the bed rest. That also in lateral position because of dislocation, all these things. Uterus fall over this in Benakava out patient. So we have to put her in left lateral position, their free circulation will be there. Maternal nutritional supplements is that is supplementation I told you. Apart from protein, carbohydrate, all these things, it's antioxidant. Hematinic, very good hematinic. This is iron supplementation, specifically iron. As per the WHO, 60 milligram of iron for at least 3 months you have to give. As per of the Indian government, 100 milligram of iron at least for 100 days we have to give on this thing. So iron is very important apart from this other on this thing you have to give on this thing. So oxygen therapy if necessary IUGR not adequate oxygen is meeting on this thing. And again that is if it is any unpurpose they are saying IUGR patient already they are said 75 to 100 gram of aspirin can be given the baby from this 12 weeks onward, 16 weeks onward. So that already increase this is blood supply to the baby. That is answer. Steroid, again, that is also steroid has again this is role of improving fetal lungs maturation, all these things. Any respiratory distress syndrome, if that is that fetal lungs, specifically if you are planning to terminate early termination, you have to improve the lung maturation. We are giving dexamethasone 6 milligram 4 doses every 12 hours, or there's betamethasone that is given. So at least you should give the steroid to enhance that is the respiratory system or the fetal lung maturation. And fetal surveillance as any detected IUGR should not be taken lightly. We have to all these things. Tell patient to at least count her daily fetal movement. Patient, how will count fetal movement? Just 12 hours. Because night we are not doing counting all these things. We tell that in 12 hours, morning to evening, how much fetal movement is there. For that, patient has to lie after breakfast 3 times, at least 3 hours in a day. She has to count all these things. Immediately after that is breakfast, she has to lie down, put her hand over abdomen and count how many times it is. If it is less than 10, again she will count again, that's after lunch. Again, while she is taking lunch, that is rest, put her hand over abdomen and count on this thing. Anytime if she counts more than 10, she will fast after lunch, she can discontinue or count all these things. But minimum per day she should count. If it is a less than that, we have to think and do other investigations. Non-stress test, again, you know all these things. What is non-stress test? It is the, that is a, it is an increase in fetal heart rate with the fetal movement. At least increase should be 15 beat and it should persist 15 seconds. So at least 2 minutes in 20 minutes, all this thing. Other biophysical profiles is NST, fetal movement, that is a tone, breathing movement, and this thing is there. So breathing movement on this thing. Amniotic fluid index. There are 5 parameters are there in biophysical profiles: gross body movement, NST, tone, breathing movement, and amniotic fluid index. That is also. Growth parameter, of course, we'll do that is a growth parameter, baby of this thing, whether baby is growing all these things. To know all these things, we have to do serial ultrasound. Single ultrasound may not be helpful for this thing. So for the, we have to do serial ultrasound, so that we can know the growth of the baby. That is a sign. So ultrasound is very much important. That not only the growth of the baby, you can know the symmetrical, asymmetrical. So symmetrical prognosis is different. All these things. So this is all these things. Time of delivery, time and mode of delivery. That you have to see that is if it is no asphyxia, fetal asphyxia, you can allow her go till term and deliver vaginally. But if any time there is, then you have to terminate it. More time and place of this delivery. So you have to do the fetal survey, uterine surveillance of the fetus will see anytime will be fetal distress, all this thing you have to terminate all these things. And otherwise you can allow her till the time and then you can deliver. This mode of delivery again it depends upon. If it is a normal, no added complication is there, you can give her vaginal delivery. But anytime there is a fetal asphyxia, all these things, it's very small baby. Then better she cannot tolerate for this. That's this head compression during vaginal delivery, pressure during vaginal delivery. So you can do elective cesarean. So electively you can do cesarean section for these babies, all these things. So this is all this thing, and it's oligohydron, severe oligohydron, fetal distress, all this thing. Apart from this obstetric indication, you can address all this thing. Very premature bleeding because again this vaginal delivery. There may be increased intracranial hemorrhage. So better to be with any aspects as we deal with cesarean sections. Cesarean sections again that is if it is dysplasia, late dysplasia is there. So that is all this thing is there. So first thing early identification and monitoring the baby. The cause of this IUGR. You have to find whether it is hypertension, it is anemia, all these things. You have to treat the causes and this thing and this thing. So if nothing is there, that means suppose if there's a gestation, no abnormalities detected, only then you can allow till 37 and delay normal. If any time there will be asphyxiation, baby or indication or fetal asphyxia, you have to terminate the patient. But for that, you need sufficient support from neonatal ICU, pediatricians, all these things. If compromised baby, you can do this surveillance for this NST, modified biopsy and Doppler also. So anytime there is a reverse flow, decreased diastolic, all these things, any resistance, you have to terminate baby. This is so complications on this thing. I told that is premature baby, there is chance of that is if it's IUGR baby. Mortality is as high as 50%. But if any detects reversal flow or absent diastolic flow is there, it may goes up to 100%. The complications of this thing may have asphyxia, fetal asphyxia, meconium aspiration, respiratory distress syndrome, neonatal hypoglycemia, hypothermia, because decreased subcutaneous fat, all these things, they cannot tolerate cold, all these things. Hyperbilirubinemia, because anoxic condition, there will be, that is, that's a that is RBC destruction will be there. So there will be bilirubin, hypocalcemia, hyperviscosity. When there is an increase the red cell on this thing. Again, there is a hypervisible. There will be that blockage in microcirculations of this also. So they are necrotizing enterocolitis. This because all these things is there. So these are the kinds of percent of all these things done. So long term, again the long term outcome, what happened on this thing, they are all these things. Again, they have study have done all these things. There is decrease IQ, all these things. Over of development that is also. Then we cannot attain the normal growth pattern as normal baby. So there is a lacking of growth on this thing, lacking of IG on this thing. Again, study have shown that coronary heart disease, hypertension, type 2 diabetes, this stop and pulmonary dysplasia because fetal lungs are suffering. These things can occur if it is also that there is decrease in that is concerned. So this thing can occur on this thing if there is a IUGR. So better to deal with during the pregnancy time versus prevent all this thing so that will not come across all this condition. So this is the thing this is occurs in so this is a short in all this thing is IUGR. I think it has been taught recently also so many times, go through your book and this thing and read this thing. IUGR. Okay, it is over. So, okay, stay safe, stay home, stay safe. Okay. Okay, thank you.